2-minute anaesthesia, local anaesthetics, the basics. There's a range of different definitions for local anaesthetics. One would be local anaesthetics suppress action potentials in excitable tissue by blocking voltage-gated sodium channels. In doing so, they inhibit action potentials in nociceptive fibres and so block the transmission of pain. Local anaesthetics are weak bases. They're made up of 3 parts: a lipophilic aromatic ring, an amine group, and a link. The amine group on the tail is able to accept protons, rendering it water-soluble. The intermediate chain is a hydrocarbon chain which is linked to the aromatic ring by an ester or amide bond. This determines the stability of the drug. So amides have a longer duration of action, secondary to hepatic metabolism, and also the risk of allergy. So esters undergo hydrolysis to para-aminobenzoate, which is an active metabolite associated with hypersensitivity reactions. The lipophilic end, which includes the aromatic ring, is essential for anaesthetic activity. As the molecular weight of this structure increases, there is increased potency, lipid solubility and protein binding. Increased alkyl substitution on the aromatic ring is associated with increased lipid solubility. Local anaesthetics can be classified into esters or amides. I call the esters the early ones, and these can be CAP, so cocaine and methocaine procaine, and the amide are the more recent agents. How do local anaesthetics work? So they bind to voltage-gated sodium channels. These are transmembrane proteins and they exist in 3 states: open, closed and inactivated. The channels are open when the membrane potential in their vicinity becomes depolarized, allowing the flow of sodium from a high to a low concentration, i.e. outside to inside the cell. Most local anaesthetics have a pK between 8 and 9 and are presented in aqueous solution. The aqueous solutions of local anaesthetics are buffered down to a pH of 5, which makes them ionized and therefore water-soluble. Once it's injected into the tissue, the acidic liquid dilutes with the extracellular fluid and therefore become more lipid soluble. They then cross the membrane into the cell, into the neuron, and the pH is lower and therefore they become ionized. Once inside the neuron, local anaesthetics preferentially bind to voltage-gated sodium channels in the inactivated state, preventing it from cycling back to the resting state and thus preventing propagation of the action potential. However, it's important to note the local anaesthetic molecule can cross into the neuron but can also have systemic uptake and undergo absorption, distribution, metabolism and elation. So you have absorption into the neuron but also absorption into the systemic circulation. So as we've discussed, local anaesthetics can be esters or amides. They can be administered via a range of different routes. They can go absorption into the nerve, but there's also absorption into the systemic circulation. Factors determining absorption into the systemic circulation will be the local anaesthetic itself, the dose, where it's administered. So intercostal administration has a high risk absorption into the systemic circulation than subcut. And also use of additional vasoconstrictor agents. Once absorbed into the systemic circulation, they'll bind to plasma proteins with a high affinity to alpha-1 glycoprotein but also albumin with a greater quantity. Amides have higher plasma protein binding than esters. But remember, these agents can bind to plasma proteins, but they can also bind to membrane proteins, resulting in their mechanism of action. That can also cause confusion. With regard to metabolism, esters undergo plasma pseudocholinesterase metabolism, apart from cocaine, and amides undergo hepatic metabolism by aromatic hydroxylation, amide hydrolysis, and N-dealkylation. This is slower and therefore is a risk of accumulation, especially in liver disease. And they both undergo renal elimination, predominantly. Factors affecting choice of local anaesthetic: potency. So as you can see, the potency varies between local anaesthetics from 0.5 up to 4%. Agents which are more potent have increased lipid solubility and therefore cross the membrane. Speed of onset. This is largely dictated by the pK. Agents with a pK closer to the physiological pH have more unionized fraction and therefore increased ability to cross the membrane. Same as lipid solubility. Increased lipid solubility, increased onset. Agents with a low potency, we can give a higher dose so it has a faster speed of onset. Duration of action. Local anaesthetics bind to membrane proteins but also plasma proteins, so don't confuse this. So a protein binding to membrane proteins, the stronger that binding, the increased duration of action. This is simply an overview of local anaesthetic agents.